Hi, everyone, and thank you for joining us this evening. As Jackie said, my name is Katie Steigelman, and I'm the Director of Medical Affairs at Travere Therapeutics. We're very excited for you to join us tonight for the Cystinuria Genetics one-on-one session. I do have a special guest with me this evening. So Gina Londre is a genetic counselor at Prevention Genetics. So Gina, I'm going to give you a second to introduce yourself before we get started.
Thanks, Katie. Hi, everyone. My name is Gina Londre. I'm a lab genetic counselor at Prevention Genetics, like Katie mentioned. I've been with Prevention Genetics for 8 years now as a laboratory genetic counselor. So while I am not specifically working in a clinic or hospital setting, seeing individuals who are seeking different types of genetic tests for different reasons, we work a lot with ordering providers and patients who are getting testing through our lab. And I did my training as a genetic counselor at Wayne State University in Detroit, Michigan.
And can you just tell us for a second what a genetic counselor actually does? So if you were to be in a clinic, in a hospital setting, what would a genetic counselor do for patients?
Yeah, absolutely. So genetic counselors in the clinic or hospital setting, you can find them in a lot of actually different specialties. So some you'll specifically find them in a genetics department. Some you will find in like a pediatric setting. So, a child comes in and has a lot of different health issues and they can't quite put the pieces together of how these all correlate and interact, and they're suspicious maybe it's a genetic disorder. You can see kids in the pediatric setting to try to do a workup and see if they have a specific genetic disorder. Genetic counselors also work as another example in like a cancer setting where let's say someone had breast cancer at the age of 28, which is really quite young for a breast cancer, and they have a strong family history of other cancers. They might see a genetic counselor to look at that family history, see if genetic testing is appropriate, might show that there's a genetic predisposition to their cancer, which then would inform their treatment and management. So really it's to help guide people into if genetic testing is appropriate or warranted for them, and then what it can do for their care and management.
Perfect. Thank you so much. So now we're really going to jump into this. And so as Jackie mentioned, we have this Q&A box on the right-hand side of the screen. So as questions come up, as they pop into your mind, feel free to type those in. If they fit in with what we're talking about, we'll answer them, or we may hold off to the end of the presentation if they would fit better there. But again, feel free to ask any questions. Gina and I are here to help. So as I always have to say as we begin these presentations, this presentation is intended for educational purposes only, and it doesn't constitute medical advice. So please seek guidance from your physician if you have any further questions. So what are we going to talk about today? So really before we can get into genetics, we really need to talk about some definitions, some of the language that Gina and I are going to be talking about through this presentation, just to get your mind centered on genetics and what we're talking about. And then we're going to talk about DNA. So we're going to talk about genetics 101. So what is DNA? How do we have DNA? How do we get DNA? What does it look like? What does it mean? And then we're really going to dive into the genetics of the disease. So we already have one great question in the queue about the genetics of the disease. So I will definitely touch on that as we get into the genetics of cystinuria. So like I said, we're going to talk about some definitions first. So what are these words? And again, you're going to hear Gina and I talk about these throughout the presentation. So when you think about genetics, you might hear a term, and it's called nucleotides. And we'll see a picture of that on the next slide. But nucleotides are really the building block of DNA. And DNA is what makes up the proteins in your body, and these proteins are what make up you. So I always kind of think about, I'm sure most of you have seen the Jurassic Park movie, like the original Jurassic Park, and you have that little DNA guy go around, and I think about them when they're sitting in that vehicle at the beginning of the movie, and they're talking about DNA. So think about that. So a gene is a specific group of these nucleotides. So we have these nucleotides, we have them in a specific order, and that's what makes up genes. And we're going to, again, talk about this more in the further slides. I'll give some examples that will make it a little bit easier to understand. When we're talking about you and your genetics, actually what your DNA says is a genotype. So think about it like the words on the front of a book that says the title of the book. that is, your DNA is saying those words. But when you see the phenotype, that's what the outward appearance is, or kind of what things look like. So you can think about it. I have the genetics. My DNA is for blue eyes. So when you look at me, my phenotype is blue eyes. Or for my book analogy, you see the words on the front cover, the DNA, the letters make up those words. And then you have, what color the words are, or the font. That's the phenotype. So kind of how it looks, those observable characteristics, those outward features. So again, easy way to think about it is, blue eyes, brown hair, that ability to curl your tongue, those sorts of things are outward features.
I think another good way too, like just to play off of what Katie is saying, if you think of like when you build a house, right? Your blueprint, that's your DNA. The house itself is the phenotype, right? Like you can see the physical house once it's built.
Yeah, no, that's great, and we'll have some more building analogies later on, because I think it's a really great analogy to kind of think about this. So I put this quote up here because I think it's a really kind of impactful quote, and it makes you think, and it makes you really understand DNA. So Francis Collins, he's the current NIH director. He actually helped do a lot of things for genetics that we don't have time to get into right now. But he has an amazing quote, and he says, the quote is, "What is DNA?" He was asked what DNA is, and he says, "It's a history book, a narrative of the journey of our species through time. It's a shop manual with an incredible detailed blueprint for building every human cell. And it's a transformative textbook of medicine with insights that will give healthcare providers immense new power to treat, prevent, and cure diseases." So again, you have to have that blueprint that Gina mentioned. We have to understand that blueprint so that we can see the phenotype, we can see the building, so then we can go on to treat, prevent, and cure diseases. And we're going to talk about all that and how it relates to cystine stones in a few minutes. So what's DNA? We said those words, we've talked about these words, so really what is it? So as I mentioned, DNA is made up of nucleotides. So hold on, I gotta find my pointer. It's up here. I'll drag it down for you guys. So here's what we have is DNA. So these nucleotides are these letters that are in here. So each letter has a pair. They have a pair they like to bond with, they stay close together. Always goes, guanine, which is G, always pairs with C. And so they always pair up. One time they're on one side, one time they're on the other, but those are always their buddies. And they pair up and they make C and then A here. And so they make orders. So 3 of those together are the nucleotide here. And a nucleotide makes up an amino acid. So 3 of these nucleotides together, 3 of these G's, these C's, these A's, are a nucleotide, are an amino acid. And these amino acids make protein. So you have this code, and they all stand for something different. And this code is what comes together, and it makes proteins. So all of these amino acids that are down here, they make proteins. And I think we'll explain it a little bit better in this next image here. So, like I said, we have these nucleotides, and they make up the building blocks of DNA. So these nucleotides build this, we're going to stick with this house analogy, and they all come together, and they all build together. And each one is a little different one. So the one might be the bottom right block, and the other one codes for the bottom left block. And then the next one codes for the second level left block, and so on and so forth. You can have changes to these nucleotides, and this is where genetics really comes into play. And you have these changes, and what these changes do is sometimes the changes cannot really mean anything. So let's take these for example, and I don't want you really to get bogged down with this information here. I just want you to kind of look at these letters and see, okay, so this person has TCC, and it codes for this amino acid. So it got changed to TTT, but it still means it's this. So that mutation doesn't really mean anything to that person. But this person, it was supposed to be TTC, and it got changed to ATC. So that makes a stop. So that genetic code just stops at that point. So if it's supposed to be, for example, if you're supposed to have 30 blocks in that building and it gets to this guy, it's going to stop whether you have 5 blocks, you have 15 blocks, or you have 25 blocks. Then we have a couple of different types of mutations, and these make different amino acids. And so those amino acids mess up your protein. And so that's what we see a lot of the times in cystinurics, is that you have these changes and they make that change to the protein. So you can think about it again with this building block analogy. So here are my building blocks. So I could have one mutation that's down here. And if I have this mutation that's down here, this is really going to affect my building. I don't want to have a mutation that's, down here. This is one of the building blocks, one of the foundations. But maybe if I have a mutation up here, that's really not going to affect it. So if we go back, maybe this mutation would be that bottom part of the building. And maybe this mutation is that top part. So that's how you can think about it. Gina, is there anything else you want to add to this?
Nope, I think that was good. Yep, that depending what type of mutation and where it is in the gene, it can ultimately result in something that's more impactful or less impactful in how it affects you.
Yeah. For the next slide, this is another different way to look at it. So we'll talk about cystinuria specifically in the next few slides, but some of you may already know that it's a transporter defect. So basically what happens is the cysteine can't go from your urine back into your bloodstream. So here's an example similar to what we just showed, but we're looking more at a biological example here versus a house example. So if this is your normal transporter, you have, you start with 8 hexagonal proteins. What you can find is that in a normal channel, these guys are just flowing through. If you have a mutation and part of it may be chopped off, maybe it can only allow one through. Maybe these proteins can come through, but it's really hard, so it's very slow. Or maybe you have a mutation, so it's no longer this green circle here, but now it's a red star, and still we started off with 8, but now we have a couple that have been able to get through, but we still have a lot. It's still heavily concentrated up here, and the flow through this transporter is really affected. So when we start talking about cysteine stones here in a few slides, you can really understand that. Another way to look at it is really to kind of think about disease states. And I'm going to ask Gina to jump in here a lot on this one, because when I think of something that's really easy to understand, I want to think about how I see it. So whether it's that building analogy or the image that we just showed, I want to think about it. So a good example of a genetic phenotype, or that outward appearance, is sickle cell disease. So normally your red blood cells always look like the donuts that we see here on the left-hand side of your screen. Your red blood cells always look like donuts. They have that little concave center area. But in sickle cell disease, your red blood cells are shaped like a sickle. So you can actually see that outward appearance. And this is what causes problems, causes blockage in your veins. And so this is what causes the problem in these patients. So Gina, are there other examples that you can think of that would be a good genotype-phenotype correlation?
So I was doing a lot of thinking on this one, and I think sickle cell is a very good example and very clear example of how the gene change directly impacts what the protein looks like. And in this case, it's the red blood cell. Another that I was, it's the person visually, you can tell the difference, but maybe it's not the specific protein change. But if we think of something like dwarfism, so achondroplasia, that impacts how well the bone and the brain tissue builds. And so that directly results in shortened bones, which of course someone with achondroplasia, then you can see them being shorter than usual, right? So it's not as, I think it's a direct show of like sickle cell, how you can say, here's the genetic change and it directly impacts how your blood cell looks. So that's like sickle cell disease is a really good demonstration of that. Whereas there's a lot that also then kind of have those really zoomed in changes, right? Like really deep in the cell change that then you can kind of see the change bigger. So I really think sickle cell is a really good example of that. Yeah.
And when we think about you guys, and again, as we start to get into the cystinuria section of the talk, yours is really tiny, really microscopic. Your mutation is in a transporter inside your kidney. So you really don't have any outward phenotypes. that we can say, like to Gina's point, you don't have the shorter stature, or you don't have, again, going back to the eyes, different eye color are technically they're different genetics. So they could be called mutations, even though it's normal to have, blue eyes, and it's normal to have brown eyes. So how are mutations passed on? And before I get into that, I just want the person that just asked that last question, could you just put in some clarification around that, just so we can better understand what you're asking there? And I have seen, Andy, your question about the renal cell carcinoma, and we will get to that at the end of the presentation. So how are mutations passed on? So here we can see a couple of different examples of how mutations are passed on. So we have autosomal dominant and we have autosomal recessive. So dominant, it's a stronger trait, whereas recessive, it's not as strong of a trait. So when you have something that's autosomal dominant, typically you have one affected parent. It's not always the case, but typically you have one affected parent. So this gene is really dominant, so it wants to take control. So if you think about your genetics, if you remember back to high school biology, and I didn't put a slide up on here, Gina, we didn't think about that you get one copy of your genes from your mom and one copy of your genes from your dad. So you're going to get one copy from mom, one copy from dad, and that's going to make you. So when you have a dominant mutation, you only need one copy, just one copy, and then you will have that phenotype because it's so strong, it's so powerful. So here in this example, the father does not have the mutation, but the mother does. And remember, so she has two genes for everything. So she has the chance to pass on a normal gene to her child or a mutated gene. So she has a 50% chance. So if they have 4 children, she has a 50% chance of having affected children versus non-affected children. Because remember, her husband, the father, is always going to pass on a normal gene. So he gives normal, 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 normal. And then she has a 50% chance of passing on a normal gene and a 50% chance of passing on an affected gene.
So sometimes when we talk about this too, I think sometimes when people look at like this little chart here, some people sometimes will ask the question like, okay, so if I have 4 kids, I'm going to have 2 that are affected and 2 that are unaffected. And that's not the case. It's with each time you have a child, there's a 50-50 chance they would have it and a 50-50 chance they wouldn't have it. So it's not that you collectively would have 4 kids and 2 will definitely have it and 2 definitely won't. You could have 10 children and 3 would have it. You could have 2 children and both have it because it's just a 50-50 chance with each child.
Mm-hmm. No, I think that's a great point. And so then autosomal recessive, again, we're looking at it. We have the parents here. So again, mom and dad each bring 2 genes to the picture. Now mom and dad both have 1 normal copy and 1 mutated copy. So when you look at their children, I think this example is a little bit easier to kind of follow. They both have 1 normal copy. So they have a 25% chance of having a child that has both normal copies. Then here, maybe they get 1 normal from dad and 1 mutated from mom. So they have a 25% chance of being a carrier, just like their parents. Here, it's the opposite. Maybe, I already forgot what I said. I think I said dad was the carrier here. So here, mom's the carrier, and you get the mutated one from mom and the normal one from dad, but you still have a 25% chance, a 50% chance of being a carrier. And then affected, so you get both mutated genes. So you get the mutated gene from dad, the mutated gene from mom, and then you are the affected child, because in this case, it's recessive. So you have to have both copies of the mutated gene. So unlike mom and dad, they may not have that phenotype. Mom and dad may be normal. They may not show any signs. They may not show any symptoms. And then comes along one of their children, and all of a sudden they're showing symptoms of the disease. So this is the case for Cystinuria. This is an autosomal recessive disease, and we'll get into more of that in a moment.
Yeah, and if you're trying to think of like what's like another way to visualize these, like dominant compared to recessive, think of like dominant disorders like a bicycle, right? You have 2 wheels. They roll, they function, they do what they need to do, but you pop a tire and bust the rim on one of your wheels. Your bike's not going to work anymore. So a dominant disorder, you have to have both copies of your genes or both of your wheels working to not have the disease. But if you have one wheel that stops working, you're going to have a bike that's not working, you're going to have the disease. Recessive, think of it like a toaster. You can toast out of both slots of your toaster, right? If one side stops working, you can still make toast, so you're fine. You carry it, one slot doesn't work, but you're fine. But then if both slots stop working, no more toast for you. So now you're affected with that disorder.
I really like that, Gina. I'm going to have to steal that. I hope you haven't patented it because I'm going to steal it.
You can have it. You can definitely have it.
But I'm thinking, I'm like, well, what if I wanted to make a sandwich? Like, then I'd have to toast one piece and then toast the other piece. That's where my mind's going.
Yeah. You'd still get your toast. It's just a little slower.
I still get my toast. It would just be slower. Correct. So we're not going to really talk about this slide a lot, but I just wanted to let you guys know because we did have a question that kind of relates to this. So there are X-linked diseases. So there are diseases that are linked to what we call our sex chromosomes. And some of those diseases, Gina, I'm going to ping you to give me a couple of common sex-related. All I can think of is color blindness. What else is on the list?
Yeah, so color blindness is a really good one. So red-green color blindness, usually a mom can carry it on her because moms have two X's, or I guess females have two X's, males have an X and a Y. So mom would have the red-green color blindness on one of her X's, but she has another working X, so it doesn't really impact her color specification. But then if she passes on that X with the red-green color blindness, and because her son got a Y from his dad, he would be red-green colorblind, right? So that's a really good example. Another one is called hemophilia. So that's a bleeding disorder. So that's where a person's blood doesn't clot like it should, so they have bleeding issues. And so usually that's one where moms can carry it and probably won't have any symptoms of it, but they can have a son affected with more severe hemophilia where they have to be really careful because it can cause really easy bruising, really easy bleeding, where then they have to end up in the hospital getting a lot of infusions to make their blood clot so they can heal.
Mm-hmm. No, perfect. So we're not going to really spend a lot of time on this, like I mentioned, but I think it does lead to one of the questions that I think Gina and I can answer on this next slide when we're talking specifically about how cystinuria is passed on. So as I mentioned before, it is an autosomal recessive disease. So again, if you look back at our image over here on the right-hand side of the screen, both your parents are carriers, and then you get one affected copy from mom, one from dad, and you have a 25% chance. So each sibling, each child that comes out of this union has a 25% chance of being affected. So what does that mean? It means that it leads to a non-functional transporter in the kidney. So there are two genes that are actually affected in this disease, and they're both members of the solute carrier genes. So again, transporters in your kidney. So we had a question earlier, and it's, what is the percentage of cystine stones in men versus women? And so again, looking at our genetics here, this image just happens to be an affected little girl here. But again, each of these siblings have a 25% chance. So we just talked about those X-related disorders. So this is not sex determinate. Men and women have an equal opportunity. This is an equal opportunity disease, as we sometimes say. So there's no difference between men and women. Now, in some cases, if we want to talk about stone disorders, and you want to let me go down a little rabbit hole right here, there is the likelihood that men might have more of a phenotype than women. Historically, men have jobs that are more outside, more physical. You exert a lot more energy. So that water that you're drinking to dilute your urine actually leaves your body a sweat. So then your urine still becomes concentrated. So even though you might be drinking that 4 liters of water like you're supposed to per the guidelines, you're sweating out a lot of it. So your urine is still concentrated. So you might have heard or seen something that, men might have more stones. And that's really around that. It's also around diet as well. But now we're seeing more in the literature that men and women are actually getting stones at about the same rate now in other stone disorders. So you really can't attribute it to diet and jobs anymore. But going back to your original question, it's an equal opportunity disease. There's no less likely chance that you're going to get it if you're a man, or you're more likely to get it if you're a woman. You both have that 25% chance of getting the disease from your parents.
And I think just to touch on the other question too, I think the question of how many generations does the cysteine filter out, I think what that might be getting at is sometimes people hear the phrase of like things skip generations. And it's not actually that genetic disorders skip generations. And we'll touch on this more later on, so I won't talk too much about this because I know Katie has it in here too. But it's not so much that things skip generations, as you can see here, what are the chances a child might be affected or not affected. So maybe you wouldn't see it in the generation above, but you see it in your children because it's recessive. But then also, and this is we'll talk about later, people can present differently even if they have cystinuria, right? People have variable presentation, which might make it seem like it skipped a generation, but maybe just someone wasn't as severely affected as another family member.
No,
I think that's what that question means.
I thought it might have been that too. So hopefully, let us know if that doesn't answer your question about the generation question. So when we talk about genes, and let me get rid of my pointer here, I got nothing to point at. So like I said, we have the solute carrier transporter. So we have two genes that are affected in cystinurics. So maybe you have the SLC3A1 gene that's affected, and maybe somebody that you met through the ICF Facebook page, they might have the SLC7A9 gene affected. But in your family, your mutations are going to typically be the same. We know that there's more mutations identified for the SLC3A1, so about 100 different mutations have been identified there. For the SLC7A9, about 60 different mutations have been identified there. And there are some instances that you have a combination mutation as well. But I don't want to get too much into this and get too much down the rabbit hole because, as you'll hear later on in our conversations, we don't do a lot of genetic testing in this population. Not a lot of people have been genetically tested. So what do these genes do, and where are they located? So when you think about your kidneys, here's your kidney. This is like your kidney bean shaped organ. So think about a kidney. And then we go into this tiny little section here, and we have the nephrons and the collecting ducts. So basically what your kidney is a giant filtrating system. So you have all these things, whether they're in your blood or your urine. And sometimes we want to keep things in the body, so we want to put it back in the blood so it can keep recirculating. And sometimes we have things that we want to take out of the body, so we want to push it into the urine so you can excrete it out. So what happens with cysteine is that we want to put that cysteine back in the blood. We want to reabsorb that cysteine from the urine and put it back into the blood. And so that happens here in this nephron collecting duct area. But what happens is that these transporters that are on the surface of the proximal tubule, which is right here where this white square is they're not there anymore, or they're mutated. So they don't work right. So looking at our next slide, here's that transporter that's on the proximal tubule, right here. And here's your blood up here. We're going to say this top part is blood. This top part is urine, and this bottom part is blood. So normally, things go through. They go out of the urine into the blood, out of the urine into the blood. But when you're a cystinuric, that's not working right. And maybe it doesn't completely stop working. Maybe it works a little bit. So some of it comes out, so your urine's not as concentrated. Or maybe it's not quite as mutated, so a little bit more comes out, but you're still concentrated up here. So you're still going to have a high concentration of cysteine in your urine. And that's when your stones start to form. But to Gina's point earlier, this is also why we see different phenotypes and why some people produce many more stones than others. So if everybody was on a level playing field, you all ate the same diet, you all drank the same water, you all did the same thing throughout your day, Sam Smith over here, where's my hand? Sam Smith over here might, be this scenario, whereas Sally Rogers over here might be this scenario. But if you have Sam Smith and Sally Smith, they're likely going to be the same thing here. So if you have a brother or a sister, you're going to typically have that same genotype mutation. But again, your phenotype still might be different for this disease, and we'll go into that in a second. Gina, anything you want to add to that?
I think so. That's good.
Perfect. So let's go on to a polling question, guys. So I really want to know how many of you have been genetically tested for your disease. And if you're a caregiver, the patient that you care for, your child, your spouse, your brother, sister, whatever it may be, have they been genetically tested? And I always apologize at this point because we don't have any Jeopardy music. We don't have any hold music. But I'm going to give you guys a few.
I can help out.
So I know I got more people out there in the audience, so. So, okay, we've got, one or two people that have been tested. So now I'm going to move on to my next question. And I'm sorry, I'm going to pick on that person. So why did you get genetic testing? Was it your family member had the disease? Was it for diagnosis? Was it for insurance issues that they wanted to show you had the disease? Or was there another reason? And if you have another reason, I really would like you to put in that Q&A box what that reason was. Ooh, interesting. More people have genetic testing now.
Remember, we really want to know why if it was other.
Okay, so we've had one person. I'm hoping those other two people are going to write it in that Q&A box if they have the opportunity to. I know you might be on your phone or something, so it's not as easy. But we had one person that said diagnosis. So, and that does happen. So sometimes, you could say your sibling has the disease and you want to know if you have the disease. You may not be experiencing symptoms at that point. And so you just go ahead and get genetic testing. Gina's company offers genetic testing for this. There's a number of different locations that offer genetic testing for this. In some cases, some of you might be saying, well, my brother has it and I wanted to find out if I had it. I didn't get genetic tested. In this case, for our disease that we're talking about today, you can do a 24-hour urine collection as well. And you can look at that cysteine level in your urine also. And that's a way you can be diagnosed as well. But there are some diseases out there that you would have to do a genetic test to have a diagnosis. We're going to talk about some guidelines here in a second. We're really going to dig deep into, should you get genetic testing? Would you get genetic testing? Why do you need to get genetic testing in this disease? So we talked about mutations a minute ago, and that we have these two different genes. One of the genes has about 100 different mutations. One has about 60 different mutations. There's some that has mixed mutations. So what does my mutation mean for me and for my disease? Well, before we get into that, there are a lot of diseases out there, and I'm really going to pass the reins over to Gina for this one, that genetics is really important for treatment. And then I'm going to jump on to the next slide and talk about genetics and the importance of treatment for cystine stones. So Gina, can you talk to me a little bit about why some diseases have that genetic component and that is really key to treating them?
Yeah, absolutely. So I think you have some really good examples here. So, and I have a couple other examples too. So I think one very apparent one is cancer-related stuff. So if you know the genetics of your cancer, because there can be a lot of different genetic changes in a tumor, but there's a lot of therapies that are specific to the genetic changes in those tumors that can then decrease them or get rid of them entirely. So there's a lot in the cancer world focusing on genetic-specific therapies, either of the tumor itself, or if individuals have a genetic predisposition to cancers, if there's other things that can be done. So I think some other ones that, kind of are more in my wheelhouse that I think of. So another big and upcoming ones. So like there's a disorder called Duchenne muscular dystrophy. Some of you may have heard of it. So it's one of those sex-linked ones where boys, rapidly they start losing their ability to walk, and pretty soon by their teenage years, they might be wheelchair bound. And then it results in an often earlier death than going into adulthood. So it's in the past was pretty tough, but there's a lot of now specific gene treatments coming out where if we know the specific cause in their DMD gene, there's targeted therapies that these boys are regaining, or not regaining, but keeping function of their muscles, and we're not seeing that early decline. So it's really amazing. Similar, if you have time, Google spinal muscular atrophy. That's another common one we don't probably hear about as often. It doesn't feel as common, but actually it's one where people are more commonly carriers of it. It's a more common one. But for spinal muscular atrophy, up until recently, a lot of the babies who were severely affected were passing away before their first birthday. So I think that's also probably why we don't hear about it as much, even though it's a more common one. But there are some very specific targeted treatments that are based on their genetic makeup that these babies are now living longer. And so far, it's so new. So there's a lot of these babies are still 2 or 3 years old, but a lot of them would have not made it even to that point, and they're doing really well. They have a lot of good muscle strength, and so it's really amazing. And then I think on the flip side, you can also want to be careful that genetic testing can make sure that you're not getting a treatment that's actually going to harm you because of your genetic makeup. So there's, we've heard of warfarin. That's a blood thinner. So certain people have different genetic variations that cause warfarin to either be used quicker, so you need a higher dosage, or it can be, if you have the regular dosage, it can actually harm you. So knowing that can be helpful with dosage. Another one that I'm thinking more of like specific different genetic disorders is like there's a seizure disorder, that there's a common seizure medication that is used to treat a seizure disorder. But if you have this one specific genetic disorder that causes seizures, that therapy can actually result in a decline a lot faster and potentially death for someone with that disorder. So it's really important that you identify that it is or isn't that specific seizure disorder, because that medication shouldn't be used then if that's what you have.
No, I think that's a great example. Mm-hmm. Yeah. And, I always think when you're talking about your cancer examples, I always think you can think of those commercials that are on TV a lot now. If you have HER positive, they're talking about metastatic breast cancer a lot. And so they're saying these like weird abbreviations, and that's what she's talking about. Those are the genetics of that disease. So those treatments are specifically for patients that have that. So they'll actually do biopsies of the cancer and do genetic testing on the cancer to understand what's going on there to make sure they're getting the right treatment. We just got another question in. I'm going to hold that one off to the end as well, but just know that I see it down there about your daughter, and we will get to that in a little bit. So when we talk about genetic testing for cystine stones, there's a little bit difference depending on what literature source that we look at. So in 2020, and if you guys have listened to me talk at any other presentations this year, you've probably heard me talk about the Cystinuria consensus paper. So this was published in 2020. And what they say about genetic testing is that there's no clear indication for genetic testing since the phenotype of cystine stones don't appear to be based on the genotype. So again, going back to those definitions, you could have one mutation, and think about it in a family. You have 2 children and they both are cystinurics, and you have your one child that is constantly passing stones, constantly having to go in for surgery, and your other child is doing just fine. So, knowing the genetics there really isn't going to affect the way that you treat them. You're going to treat them the same way. They're cystinurics. They're going to go on the same medication. They're going to go on the same therapeutic lifestyle changes. So they recommend that you don't need genetic testing for these 2020 Cystinuria consensus paper guidelines. The AUA guidelines, so that governing body for urologists, the American Urological Association, they also don't say that genetic testing is necessary. Again, like I mentioned earlier, you can do a 24-hour urine collection and you can look at the concentration of cysteine in your urine. So Gina and I are going to have very low concentrations of cysteine in our urine. We may have, in a 24-hour urine collection, we may have 3 milligrams of cysteine in our urine, where you could see upwards of thousands in a cystinouric urine. So it's very obvious when you do a 24-hour urine collection that you're affected by this disease. So also in 2020, another guideline came out. This came out of the EU, so out of the European Union. Most of the authors were either from the UK or countries in Europe. And as we know, and again, if you've heard me talk before, you know that there's a much higher prevalence for cystine stones, or if you're on the International Cystinuria Facebook page, you know that a lot of the times the individuals are from the UK that are talking on there. So they actually do recommend to do genetic testing over there to help counsel the family. So again, you know if your children have it, you know how it's being passed on, you know what genes are mutated. And they say there is no strong genotype-phenotype correlation, but they still recommend it. So I'm going to have Gina kind of see if Gina can touch on country differences. And, is it a reimbursement issue? Is it there's easier access over there? Maybe even there's more research going on over there. So they want to know what's going on in terms of genetics.
Yeah. And so, I think, I think you're right, Katie. I think it's a matter of how common is the disorder in the United States compared to elsewhere. So I think they say globally, so now this is a global average, that 1 in 7,000 people have cystinuria, but in the United States, it's more like 1 in 10,000. So I think we kind of increased that average, whereas some of the information I saw, there are some populations specifically that do have a higher incidence. So, like in Turkey, as an example, 3 to 4% of the population can have cystinuria. There's also a specific group of Libyan Jewish individuals that 1 in 2,500 individuals can have cystinuria. So, I think the idea is if there are higher prevalence of cystinuria, you can, determine if it's a genetic, if your genes are causing it, right? If there's a genetic reason for it. And then also probably to help with, as kind of the consensus guidelines said, to help other family members potentially who may then also develop cystinuria. And, I think part of the access piece of it that Katie was talking about, in the U.S., we often are bound by insurance, and is insurance going to cover genetic testing? And a lot of the times in the United States, if they don't feel that genetic testing is going to change management, which is a lot of the times the case in cystinuria, insurance doesn't cover the genetic testing for it. Every insurance company is different and it varies, but kind of broadly, that's kind of the Medicaid, Medicare guidelines that if it's not going to ultimately impact management, it's not going to be covered. So I think it's harder that way. Granted, we have a lot of access to it, genetic testing labs in the United States. I think the payment piece is a tough part of it. Whereas I think abroad, if we think of some of our European countries, a lot of them have a socialized medicine type setup. So the government's paying for healthcare, and some, from their perspective, they might say, yeah, this makes sense. We'll pay for genetic testing. So it's easier for families to get in that regard. So it's probably a few reasons, right? This disorder is more common in different places, and also the insurance payment structure type setup probably plays into it too. And I think with cystinuria, like everyone knows, like all of you know, Katie's been talking about, it's one of those where you can do your urine collection and get diagnosed that way. And so I think the emphasis in certain countries is just maybe placed on different diagnostic methods.
Mm-hmm. No, I think that's great. So yeah, and I totally agree with you. The higher prevalence over there, as well as the accessibility and ease of getting it reimbursed, are really, the top things. Because if we go to this 2020 Cystinuria Clinical Practice publication that was from the UK and the EU, there weren't any US authors on it. The consensus paper was published here in the US, and it was only US authors. So even though it was urologists and nephrologists and it had pediatrics on there as well, they were all, US based. But one of the things that we do see here is that, both of them say, really that therapy, their therapy isn't going to change based on your genetics. So it's very interesting for Gina and I. I'm sure we would both love to know the genetics of people and kind of more stones, other stones, the other causes. Why does your sister have more stones than you do? I'm sure, people like Gina and I would love to dig into that. It just doesn't make a lot of sense to genetically test everybody if we can just look through urine. So with the last part of the talk, and you guys that we haven't answered your questions, I haven't forgotten about you. I see them down there. We're just going to talk about what else affects your disease. So we've touched, it's a recessive disorder in the family. You're probably going to have the same mutation. So why does my sister get more stones than I do? So what else can affect your disease? So before we get into that, we'd like to know our audience a little bit better. So do you have a sibling or a relative who's also been diagnosed as a cystinouric? All right, so we're running about 50-50. So the 50 that maybe said no, maybe they don't have any siblings, they might be an only child, or maybe, to our point from earlier, you only have a 25% chance. So, another disease I've worked on in a past life, Gina mentioned 10 kids. They actually had 10 kids, and it's an autosomal recessive disorder, and they had 3 children that were affected. So that's not that 25%, chance when you think about it. But again, it's 25% chance each time. So the next question for those people that answered yes, I have a relative or a sibling, do they seem to have the same phenotype as you, or are they totally different? Like we've been talking about in these examples, that one sibling makes a lot of stones and the other one doesn't hardly make any. Or do you both pretty much, you both had, X number of surgeries, you pretty much have a very similar stone rate. So very, very interesting. So what we're coming through here is that they don't have the same phenotype. And so that's commonly what we see. So why is that? And so I'm going to jump out of this poll and move on to the next slide so we can kind of go into why siblings might not have the same phenotype. So genetics and the environment really play hand in hand, especially in this disease. And so that's one of the main things. But also, different types of genetics can play a role for patients. So we know, for example, that urine pH plays a big role for you as a cystinouric. So I'm sure your doctor has heard you and talked to you about, getting your urine pH to 7, to 7.5, above 7, however they're wording it. They want your urine pH to be higher because cystine is more soluble at a higher pH. Somebody asked a question and they're talking about potassium citrate. You may be on potassium citrate to increase your urine pH. Well, maybe, if you think, again, I'm going to use Gina and I as an example, normal urine pH is around, like 6. It's, anywhere from like 5.5 up to like 6.5. So maybe my urine pH is closer to 5.5 and Gina's urine pH is closer to 6.5. So there's dietary factors that are going to affect our urinary pH, but could there potentially be some other mutation in your body that is causing your urine pH to be slightly different than the normal? Yeah, there could be. Do we know what that is? If you weren't a cystinouric, do we really care? Does Gina sit at home and test her urine pH? I mean, I don't know what Gina does in her free time, but I don't.
Comment. No, I'm just kidding.
So, maybe that's affecting your stone production. Maybe you always have, a lower urinary pH, and so your urine's more concentrated. And so maybe you have to take more potassium citrate to get that up. So that could be, you could have some other genetic interplay going on inside your body that you don't know about that could be different from your sibling, or that could be different from the person down the street that's a cystinouric. As I mentioned, environment's a big factor, so we've talked about, I talked a little bit about earlier about, if you sweat out a lot, that water that you're taking in is coming out as sweat, not as urine. So, location could be a big part. So if you live in Florida like I do, and it's, 90 degrees for 10 months out of the year, then I'm probably going to sweat a lot more than Gina does living up in Wisconsin when it's 90 degrees 2 weeks out of the year. She's probably like, it's probably a little bit hotter than that for a few more weeks. But, those location differences can cause differences. So if you have a sibling that lives, in Wisconsin and you live in Florida, maybe you both, talk and you're like, but I drink 4 liters of water, But again, I could be sweating out more and losing that liquid through sweat. Cultural aspects are another big thing. So, it could be dietary cultural aspects. So you might be taking in a lot more sodium. You might be taking in a lot more animal protein, and this could be cultural or where you live. Or I know we've had some patient advisory boards where we've talked to people that are hunters and they do a lot of hunting. And so they eat a lot of meat because they hunt and that's the meat that they eat. Or they, have a cattle farm or whatever it may be. But you have to think about dietary considerations too. So there's a lot of things that affect your disease. It's not as, cut and paste, like when we talked about sickle cell. You have that mutation, your red blood cells are going to look like a sickle, and you're going to cause clots and blockages in your arteries. We have a lot more factors that go into this disease that can cause issues as well. So, unfortunately, one of the things I always say is it's more of an art than a science. So we know the science behind it. We know you have that underlying genetic mutation. But to get to that sweet spot that you need to have your treatment work for you, we need to figure out, what does your urinary pH look like? How can we get you to that best urinary pH? Is it through potassium citrate? Okay, good, great. Okay, how much water do you need to drink? Can you drink 4 liters of water a day? Is that something that you can do? Or no, I'm a teacher and I'm, in a classroom 8 hours a day and I don't get to go to the bathroom that frequently. So there's no way I can drink 4 liters of water a day. Okay, well, let's try and figure out a different way, Or again, cultural aspects. Is there a lot of meat in your diet? Do you just really like meat and you want to eat meat a lot? Okay, then let's tone back on some other areas. Do you have to eat out a lot? If you eat out a lot, you're taking in a lot of excess sodium. Or do you eat a lot of, whoever was on my talk last time that we talked about diet, those hungry man's, those lean cuisines, anything that sits on the shelf, they're packed full of sodium. So those aren't that great for cystinourics. So there's really a lot of different things that are interplaying in your disease. So again, it's not so cut and dry like something like sickle cell, where you have that mutation, you have the phenotype, this is how you fix it. Here, we have the mutation, we know what your disease is, but we have to figure out how best it is to fix it for you. So I think that's our last slide, Gina. So I think we should go to some of these questions. We have a couple minutes. We have some questions here in the queue that we can answer. And if anybody has any questions, keep them coming. So the first question we have is someone who's had several bouts of renal cell carcinoma. And does my cystinuria affect this, or is it something that's totally different? So I'm gonna take a stab at it, and then I'm gonna toss it over to you, Gina. So when you have cystinuria and it goes unmanaged, you do damage to your kidneys. It is known in the literature that you can have chronic kidney disease. And so this is basically when you do damage to those kidney cells. So if you have another mutation or another predisposition that might lead you to have cancer, and you have these cells that are already damaged, those cells might not be able to stop that cancer from starting. So they might be so damaged that they're almost beyond repair. And when that cancer gene says, hey, and rears its ugly head, that cell kind of has to just like lay down and say, okay, I give up, take me over. So could they be connected? Potentially. I don't know enough about your cystinuria and how well it was managed and how much kidney damage you had before you got your renal cell carcinoma. But they could be somewhat interconnected, but there are no instances in the literature, if you're looking, at the SLC mutations that cause cystinuria, there's no really incidence of those then going on to cause renal cell carcinoma. Gina, anything additional to add to that one?
You hit the nail on the head, Katie. That was, yeah, I agree. And then, I think It can be tough too, because like Katie said, could the cystinuria be at play? Sure, maybe, because it's impacting those same cells. But could it be a different genetic predisposition too, and they're kind of interlocking and playing together? Sure. Yeah, I mean, that can happen too. So, certainly if there's like a family history of renal cell carcinoma or kind of similar type cancers and others aside from you, that could be something worth following up on, because maybe it's not just the cystinuria, maybe that's just impacting it too, but it could be something else entirely separate, but because they're affecting the same system, they have some potential interconnection.
No, so I hope that was able to answer your question around your renal cell carcinoma and your cystine stones. But yeah, I think, you could talk to your urologist a little bit more about that as well if you were interested, and they might have a little bit more insight. So the next question we have is really about, I think it's more like why this doctor ordered genetic testing. We have a mother here, and she's discussing that her daughter is producing a lot of stones, has been for 2 years. The mother really wants the physician to put her on a different therapy, because right now they're only managing her with potassium citrate. And then, the doctor went ahead and ordered genetic testing. So I don't know why the doctor ordered genetic testing. It could be maybe they want to place her on a cysteine binding thiol drug, and it needs to have genetic testing to get approval. We have had some instances, if we're talking about Thiola, in which the patient needed to get genetic testing before they could get Thiola. It's very rare, but that could be a rationale. It could be, I don't know, has she done a 24-hour urine collection? He might be, or has she had a stone analysis? Do we have a confirmed diagnosis of cystinuria in this patient? If we don't, and she's just producing stones, there are a lot of other pediatric rare stone diseases. So this physician might just be double checking that it is truly cystine stones that she's producing before he moves on to a different medication. Gina, any other thoughts on that? And
no, I think you got
Mom,
it.
if you want to type anything else in there, I posed a couple of questions. Has she been diagnosed with cystine stones, whether it's through 24-hour urine collection or stone analysis? We might be able to play a little bit into more of the thought process of this physician. But I think those are really the key things, is to confirm the diagnosis of cystine stones, potentially for reimbursement issues for medication.
And that might have also, now that I'm thinking about it too, that could have also been an answer to the poll question for like the other. So it could have been that too, of that's what led to the genetic testing in their situation.
Yeah. So we've got one more question. Keep them coming. I know we're 4 minutes over, so if you have to jump off, I'll let you. Hold on. Let's go back to this question we just answered. Okay, so she does have confirmed cystinuria. She has done 24-hour urine collections. So again, my thought would go back to that maybe he's just doing it for confirmation or for reimbursement issues. I don't know how competent this physician is in treating cystinurics, and maybe they feel like they need to get that genetic testing because they're not aware of the guidelines that state that they don't need genetic testing. We do know that, on average, the doctors that we talk to that follow patients, they see about 1.7 patients. So they're not following a lot of patients with cystine stones. So it may be one of the first patients they followed with cystine stones. Gina, do you find this common? This is a pediatric patient. Do you see genetic testing a lot more commonly, when a child's diagnosed versus an adult is diagnosed in a disease like this?
I'd have to look specifically, but sometimes, I mean, if there's if it's a child and they might just want to say, yep, this is definitely we're just dealing with typical cystinuria, like that might be a mechanism to feel confident in that regard, right? Like to make sure that there isn't something else at play that's, cystinuria is another component of that. So I would say overall, probably generally genetic testing might be more common in a pediatric child setting than it is an adult setting. And it's mostly because kids come to attention for things. You have your parents looking out for you and getting you in to see the doctor, and adults were not always as good at taking care of ourselves and going and see the doctor when we might need to. So.
So a continuation. So she did not previously test for cystine stones. So maybe this is, was the 24-hour urine collection done the same time as the genetic testing? Because, you're going to get the results from a 24-hour urine back a lot quicker than you would the results of a genetic testing typically. So if they kind of did it hand in hand, then maybe it was to help, confirm the diagnosis. But again, I think you're doing the right thing as being a mama bear and really pushing this physician. If she is still producing stones, then she needs to have some better management, and whether that's something that you can do as a mom by getting her to drink some more fluids and make sure she's watching her diet. Or she may need, we know that about 55% of patients will need a cystine binding thiol drug to help manage their disease. So, you're being a good mama bear. Just keep pushing and keep defending your daughter. And, if you need help to maybe identify a different physician that might listen to you better, if this physician continues to push back, I recommend joining the International Cystinuria Facebook page. The president, Gail Sweeney, will help you find a doctor in your area that has expertise with the disease. Also on her website, it's cystinuria.org. They are starting to put a list of physicians together that do follow cystinuric patients and are at stone centers. So just reading through one of these questions. So again, this is a genetic disorder, so you may see it, within your family. And again, going back, your brother had stones later on in life, you had stones earlier in life. Again, it really goes back to that disease phenotype slide that we just talked about. There are different phenotypes for each person, and that really goes back to your genetic makeup and also the environment. It is an autosomal recessive disease. You're asking about your daughters, and they have 3 grandchildren. It's an autosomal recessive disease. So the chance that your daughters have the disease, they are likely carriers. So they have that one mutated copy. They have about a 25% chance of being carriers. But, it wouldn't hurt. They could do a 24-hour urine collection really easily to see what their cystine concentration is. And they can go from there. I mean, if they're not showing any signs and symptoms, then I wouldn't worry too much, but just make sure that when they do go to the doctor, make sure that they're reporting they have a grandpa that has a genetic form of kidney stones. Gina, any other advice that you might give for that and really kind of more of the family planning aspect of the disease?
Yeah, no, I think you answered it well. I think you're probably wondering too, because you say, I saw that a great aunt had it in her 90s. And so sometimes, even though, this is recessive and you expect someone, it has to have, the recessive inheritance, but sometimes carriers can have some minor influence. Now, you wouldn't necessarily expect like how you're saying you and your brother clearly have had stones earlier on in life, you even earlier than your brother, but it might also that great aunt being a carrier could have impacted their development of stones, but obviously not until they were in their 90s. So, you truly think of it like it's a recessive disorder. So just like Katie said, making mention of that, making providers aware, but the likelihood that they would develop stones is pretty low. And maybe if they do, it wouldn't be until they're 90 years old. So.
Yeah, and one of the other things I would be interested to know is, was there a stone analysis done on that individual at 90 years old? There's a lot of other different types of stones out there. So it might have just been a coincidence, and they might be producing a calcium oxalate stone and not a cystine stone.
Yep, very true. Yep.
Gina, I'm going to leave this last question to you because I think this is right up your alley.
Okay, so let's see here, as a cysternuric mom with 3 married daughters, if they want to have children, do they advise their spouse to get tested for the cystine recessive gene? So they could, but I think, so usually how does the process work? Just so that people are aware, like, so if I were to get genetic testing, what does that look like? When we're looking at families with a genetic disorder, usually the recommendation is to test someone who has the disorder first. And that's because if someone has that disorder and we do the genetic testing and we can find the genetic cause, that makes a pretty picture, right? It makes sense. If you test someone who, let's say, in your case, let's say you went to test your daughters. Well, we know with the recessive, there's only, if they haven't had cystine stones themselves, there's only a 50% chance they'd actually be a carrier. There's that 25% chance that they wouldn't be a carrier at all. So testing them might not give a clear picture of like, well, did they inherit it? Did they not? Because you want to test the person who actually has the disorder to say, yes, this person with this disease has this genetic finding that makes sense. Now let's think about cascade testing of other family members. So it probably wouldn't be advised for their spouse to get testing. If they really felt they wanted testing, they could, like you could have testing as a cysternuric mom, see if you have identifiable genetic confirmation. Your daughters could then pursue carrier testing to see if they inherited it or not. And then from there, depending on their results, their spouses would consider carrier testing. Now, all that to say, what would be the hopeful outcome or benefit of that, right? So I guess it comes down to, would this testing ultimately change anything for them? So I think that's like more before you go down a path of genetic testing, really thinking about, we could do this, well, it doesn't make a difference. I think it'd be more of a matter of maybe just informational for in the future of, could someone be developing stones in a different generation of the family? But again, as Katie said too, you can also do urine collections to look at that as well too. So I think it just ultimately boils down to, is that something you want to know? And if you do, would it actually make a difference?
Yeah, and I think all of Gina's points are very well taken. It's, one of the things about genetic testing is it's kind of like opening a little bit of a Pandora's box as well. So you have to be really cautious. We do know that patients that are heterozygous, so if your daughters did have, I didn't use that, that's a new word, I didn't put that in the definition. So if your daughters are a carrier, they will have a little bit higher levels of cystine in their urine than someone that has 2 normal genes. So what you could always do, it wouldn't be definitive, but you could have your daughters, you could go to a very well-educated nephrologist or urologist that knows a lot about the disease, have them do 24-hour urine collections on your daughters and see what their thoughts are, and then you can kind of further decide. And you could even do it with their spouses and kind of further decide if maybe this is a path that we want to go down. And then that's really, it's just a urine collection. You're going to see, 24-hour urine collection. You're going to see how much urine they make, how much sodium they take in, all those, you can see what their normal pH is, all that good stuff. So I might want to, start with that potentially. And then if they, if there's a level of question, then maybe, again, go to Gina's point and start that cascade testing. Start with you so we can really get a handle on what your genetics are, so then we know what we could be looking for in your daughters.
Yeah, and I think what's I guess, a good thing about cystinuria, if we're talking about having different disorders, is that you do have a simple urine test that you can do. There's a lot of other disorders.
It's simple, Gina.
I guess I think of it more, there's a lot of other recessive disorders out there that are really, so I guess to kind of go off of your point of like, well, would they consider this? There's some recessive disorders, similar to some of the other ones we talked about, where babies can die within the first year if they have that disorder, and some of those are recessive disorders. So some couples want to know that they're carriers, and then they sometimes do like in vitro fertilization, so IVF, and they can kind of manage that potential risk to avoid having a baby who might have this super life-limiting condition. And so, but I think kind of benefit of cystinuria is that you can do the urine, even if it is tough to collect. So I will, I will say that.
All right. Well, thank you guys so much. And for those of you guys that stayed on the line a little bit longer for us this evening, we really appreciate it. If you have any more questions, feel free to reach out, to your nurse educators at the hub, and they can get you in touch with the right people. Again, I do recommend going to that ICF Facebook page or the cystinuria.org website. Those have some great resources there as well. So on behalf of Gina and I and Travere Therapeutics and Prevention Genetics, we just want to thank you for joining us this evening. Have a great night, everyone.
Good night. Thank you.
On behalf of Travere Therapeutics, I'd like to thank you for your participation in today's event. As a reminder, please complete the short survey that will appear immediately after we conclude today's program. Please take a moment to fill the survey out to help us in planning future web events. Thank you and have a great day.